As we start, we acknowledge that the Pragmatic Trials Training Program's coordinating teams offices, located in London, Ontario, are on the traditional territories of the Anishinaabeg, Haudenosaunee, Lenape-Awak, and Attawandaron. This land continues to be home to diverse Indigenous peoples, whom we recognize as contemporary stewards of the land and vital contributors of our society. We also recognize that our work is carried out on the traditional territories of First Nation, Inuit, and Métis peoples from coast to coast. We are thankful that we are able to work and collaborate on these lands.
Thank you for that. And hi, everyone. Welcome. I'm Liam, and I'm here with my co-host, Angela. This module was created by the HDRN Pragmatic Trials Training Program. Today, we're discussing how pragmatic trials can support reconciliation and help address Indigenous health inequities in Canada.
This module was created by non-Indigenous researchers in consultation with Indigenous knowledge keepers and Indigenous partners. We do not claim expertise in this area, and we hope to learn from our partners as we continue this work.
Exactly, and maybe we should start by setting the stage a bit. When we say reconciliation in Canada, a lot of that conversation has been guided by the Truth and Reconciliation Commission's calls to action. Specifically, Call to Action 19 is directly about health. It basically calls on all of us, especially the federal government, but really everyone in healthcare and research, to identify and close the gaps in health outcomes between Indigenous and non-Indigenous communities.
Right, and pragmatic trials have a role to play in that. If we do them right, pragmatic trials can be a tool for reconciliation, not just a method to test what treatment works. It's about how we do the research as much as what we're researching.
And just to add a layer here, there are two main ways Indigenous communities might be part of pragmatic trials. One is when the trial is conducted primarily within Indigenous communities themselves, and most or all participants come from those communities.
The other, which is more common, is when a pragmatic trial is embedded in the broader healthcare system and some of the participants happen to be Indigenous. For instance, you might have a primary care that serves both Indigenous and non-Indigenous patients, so they naturally become part of the trial population.
Both approaches matter, and both raise important considerations about how we design, govern, and share the work in respectful ways. In the past, research often took data from Indigenous communities without giving back, and was done in an extractive way that caused a lot of harm. Now, in a reconciliation context, research must be done with Indigenous communities as equal partners.
And that starts from the very beginning of a trial, the idea phase. One concept is micro-reconciliation, which means weaving reconciliation into our everyday actions. You know, those small interactions and decisions we make in research, like each small respectful act, listening deeply, acknowledging Indigenous knowledge, sharing power. Those micro steps add up to bigger change.
I love that idea. Micro-reconciliation goes beyond formal apologies and policies. It's reflected in the day-to-day actions and decisions of individual researchers and practitioners. For example, even the way we hold meetings can be an act of reconciliation, like ensuring everyone's voice is heard, or starting a meeting with an elder's blessing. Those are small things, but they reflect respect and partnership.
Absolutely. And another concept that fits in here is ethical space. This comes from Cree scholar Willie Ermine, and it's about creating a shared space where Western and Indigenous worldviews can come together respectfully. In a research context, ethical space means we approach a project recognizing that Western science and Indigenous knowledge are different but equal. So when we co-develop a pragmatic trial with Indigenous communities and partners, we actively build a space for both ways of knowing to guide the project.
Right. It's like saying, we have our scientific trial design, and you have your community knowledge and values. How do we meet in the middle? In that ethical space, both sides adjust and learn from each other. For instance, the community might want to include Indigenous materials or procedures as part of the recruitment process, and the researchers make room for that in the trial protocol. It's a two-way learning street.
Exactly. Instead of researchers coming in with a fully formed trial for a rubber stamp from the community, it means involving the community from the get-go, identifying the research question together, planning the methods together, deciding what outcomes matter. It's more collaborative, which can take more time and patience, but it's worth it. It goes back to the mantra of nothing about us without us.
And maybe we should talk about some concrete ways to do that. Like, what does co-governance or co-development actually look like in a pragmatic trial? One approach is to set up community advisory boards. These are boards made up of community members, maybe elders, youth, local health workers, who advise the trial team throughout. They can flag if something isn't appropriate or suggest better ways to do things, so that the trial aligns with community values.
Yes, and even beyond advisory boards, some projects establish Indigenous-led research councils. Think of it as the community having its own research steering committee that works in parallel with the academic one. They would have real decision-making power, not an advisory role. For instance, an Indigenous-led council might have the final say on whether the trial materials or methods can move from one phase to the next, or whether certain sensitive data can be used. It's about sharing control.
That's a good point, sharing control. It ties into data governance too. The OCAP principles, which stand for ownership, control, access, and possession. It was created by First Nations in Canada, and it basically says Indigenous communities should own their data, control how it's used, have access to it, and possess it, like physically hold it if they want. In a pragmatic trial, that might mean signing a data sharing agreement where, say, the community keeps their data on their own servers, or that nothing gets published without the community's approval. It changes the usual power dynamic around data.
Exactly. Instead of researchers treating data as theirs, OCAP reminds us that the data comes from the people and ultimately should benefit those people. There are examples where a community says, "We will own all data collected on our territory. You, the researchers, can analyze it with us, but you can't just take it and run." And any publications or presentations from the trial might be reviewed by the community first. That builds a lot of trust because the community knows they won't be misrepresented or blindsided.
And OCAP principles still apply when pragmatic trials rely on routinely collected or administrative data, like those from hospital records, billing data, or provincial health databases. Those sources might feel distant from the community, but they can still include very detailed information about Indigenous people's health.
Yeah, that's exactly right. Even if the data are technically housed in provincial or federal databases, communities may still expect agreements that recognize their right to control how data about their members is used. That could mean setting up formal data sharing agreements, ensuring Indigenous identifiers are handled carefully, or involving community representatives in deciding what research questions are even appropriate to ask of those datasets.
And in practice, it might also mean communities get copies of the analyses or dashboards that researchers create, so the insights flow back and support local decision-making. Otherwise, researchers risk repeating old patterns of extraction, where data is pulled out of communities and used mainly to serve academic goals.
Exactly. So whether data comes directly from people through trial participation and data collection, or indirectly through administrative systems, the same principle stands. Indigenous peoples should guide how information about them is governed, interpreted, and applied. That's the heart of building trust and ensuring pragmatic trials contribute to reconciliation.
It does, and actually, there's a newer set of principles to complement OCAP called the CARE principles: collective benefit, authority to control, responsibility, and ethics. CARE is more of a global framework for Indigenous data governance. It emphasizes that research data should benefit the community collectively, that communities have the authority to control their data, that researchers have a responsibility to handle data in a way that's respectful, and that ethics guide the use of that data. So in practice, applying CARE might mean, for example, that any data we gather will be used to directly help the community, maybe informing local health programs, rather than just sitting in a journal article.
These frameworks like OCAP and CARE push us to think differently. They set expectations up front, which is great. If we know, from the start, that the community will own the data and expects collective benefits, then we design the trial differently. We budget for community data analysts or capacity building. We plan to share results in community forums, things like that. It's not an afterthought. It's built in from day one.
And I want to pick up on that sharing results part you mentioned. So many times in the past, researchers would use Indigenous people's data, and then the results would end up in an academic journal that never made it back to the people who participated.
There needs to be an expectation, and I'd say an ethical obligation, to return results to the community and trial participants. In a pragmatic trial context, that could mean once the trial data become available, we work with our partners and explain in plain language what we found, maybe using a translator if needed, or even creative formats like a video or a pamphlet in local languages. The idea is to make sure our partners and trial participants have the opportunity to hear the results from us and can ask questions.
And not just hear it. Ideally, they should get to interpret it with us. Like, maybe our stats say a particular intervention worked or didn't work. The community might have insight into why, in a way we didn't think of. Maybe something was happening at the time that affected the trial outcomes. So when we share back results, it can be a dialogue. We, as researchers, can learn from how the community reacts to the data, and that can even shape how we write up the final results.
That's a really good point. It makes the research better and closes the loop. People who gave their time as participants deserve to know what came of it. Plus, if the intervention was helpful, the community can decide if they want to carry it on. I've heard of trials where, once the trial ended, the community already had the information and said, "Hey, this worked for us. How do we keep it going?" That's kind of a best-case scenario. It leads right into action.
And that hints at another piece. When we say success, how do we define success in these kinds of trials? It's not just about p-values and journal publications anymore. Success should include things like capacity building and community-defined benefits. So, did the trial help train any community health workers or research assistants? Do they now have skills or certifications they didn't have before? That's capacity building. Or did the community get something they wanted out of it? Maybe the trial brought some equipment to the local clinic that stays after, or it built knowledge to develop a program that the community cares about. Those are success metrics too.
I love that because it redefines impact. Like, sure, we want to know if the intervention worked medically, but also, did we leave the community better off in other ways? Maybe one community's definition of benefit is having its youth learn research skills. Another community might value getting funding for a health initiative as part of the trial. So we should ask at the start, what does a win look like for you, the community? And then aim for that as part of our outcomes.
It ties into Indigenous methodologies too, in the sense that we value different ways of doing and knowing. These contention sharing circles, or land-based approaches to gathering knowledge. In Western science, we're used to surveys and lab tests, but Indigenous approaches might involve narrative methods, like having people share stories as data, or going out on the land to understand health connections.
And in a pragmatic trial, we absolutely can incorporate those. For example, imagine a trial for mental health support that compares a land-based healing camp to a standard clinical therapy. The land-based approach might involve spending time on the land with elders, learning culture and skills as a form of healing. That's a legitimate intervention rooted in Indigenous knowledge. Or maybe as part of the trial's outcome measures, instead of solely using a depression scale questionnaire, we also gather oral histories or personal stories of participants to see how they feel their well-being has changed. Storytelling can carry nuance and context that a numeric scale might miss.
That's such a good example. It broadens the evidence we collect, and it also respects that evidence isn't just numbers on a scale. It does require funders and ethics boards to be on board with these methods, but I think that's changing. There's more recognition now that Indigenous methodologies are valid and rigorous in their own right.
Definitely. We're seeing two-eyed seeing approaches, where people try to balance Western and Indigenous methods side by side. It enriches the research, and it's another form of reconciliation, valuing Indigenous knowledge systems as equal to Western science. For so long, Indigenous knowledge was sidelined or outright dismissed in research. Embracing it now is part of healing from that injustice.
Now, it's not all easy. We should acknowledge the barriers to doing all this because, if it were simple, everyone would already be doing it. One barrier is time. Building real relationships with communities, trust, understanding, co-designing the trial. That takes time. And our typical grant funding or academic timelines aren't always flexible. Researchers might feel pressure to crank out studies quickly, but you can't rush relationship building. If you try to, it comes off as insincere or you risk making mistakes.
So true. Some researchers might say, "Oh, I have a 3-year grant. I don't have a year just to hang out and build trust." But maybe grants need to be structured to allow that front-end time. Like funders could provide development grants specifically for relationship building before the main trial funding even starts.
That would help a lot. Another barrier? Institutional capacity and knowledge. Not all research institutions have an Indigenous advisory office or experts to guide researchers new to this. So, a well-meaning scientist might want to work with a community, but has no idea how to start, or what protocols to follow, or even who to talk to. That can lead to frustration on both sides. The researcher feels lost, and the community might feel the researcher is clueless. And maybe they are, through no fault of their own education gaps.
This is where having support is really important. Universities, hospitals, and research programs are slowly setting up Indigenous research support offices or hiring Indigenous engagement coordinators. Those folks can train researchers, like teaching about local protocols. Also, having Indigenous people on research ethics boards can help ensure proposals are appropriate before they even leave the institution.
Yes, and having more Indigenous researchers leading trials is probably the biggest game changer long term. If the principal investigator or co-investigator is Indigenous, you already have a better chance that the project will be done in a culturally safe way, because they bring that lived experience and community connection.
What about funding structures? We touched on grants allowing more time. I'd add that funding agencies could also encourage things like having budgets for honoraria for elders, or for community feasts or meetings, or even for translation. These are things that traditional research budgets might not include. But if funders explicitly say, "We will fund your community consultation meetings, your translation of consent forms into Cree or other local languages, your elder honorarium," then researchers don't have to fight for those items. They're expected. It normalizes doing things the right way.
That's a really good practical suggestion. I think some grants, especially Indigenous-focused funding programs, already do that, but it'd be great if it was across the board. It sends a signal that this is standard practice, not an extra.
Another barrier is the knowledge gap on the researcher's side. Like you said, someone might not know where to start. There's also sometimes fear of saying the wrong thing, or fear of being an outsider. That can freeze people. It's better to start trying, humbly and respectfully, than to hold back out of fear. Be upfront about what you don't know. Often, community members appreciate honesty and willingness to learn.
And that's where cultural safety training can come in too. Many institutions offer workshops or training on Indigenous history and cultural competency. It's not going to make you an expert overnight, but it's a start to unlearning biases and understanding context. Every research team working with Indigenous communities should do some form of cultural safety or humility training together. It helps everyone get on the same page and signals to the community that you're taking it seriously.
Thank you, Liam, and thanks everyone. Let's remember that all of these efforts, whether through micro-reconciliation, ethical space, or Indigenous data sovereignty, are ultimately about fulfilling the spirit of Call to Action 19. Closing the gaps in health outcomes between Indigenous and non-Indigenous communities, and ensuring research contributes to equity and reconciliation. Until next time, take care and miigwech. Thank you for listening.